So good morning, all of you. We could have chosen a smaller aula, I think, for this crowd. I'm Jean Muris. I'm chair of the Department of Family Medicine. I'm today your pro-rector. So hereby, I open this academic ceremony in which Björn Schwander will defend the academic thesis, Systematic Evaluation, Replication, and Validation of Structural Health Economic Modeling Approaches, Lessons Learned in the Field of Obesity. So may I invite you, Dr. Schwander, to present a summary of your study and the conclusions of your thesis.
Thank you very much, dear Pro-Rector, dear Defense Committee, dear supervisors, dear audience. So I have the pleasure to present and defend my thesis today, and I will start with some facts about obesity and obesity-associated diseases. So obesity is an abnormal or excessive fat accumulation, often defined as a body mass index larger than 30 kilogram per square meter. Obesity reached epidemic proportions and is a leading risk for global death and morbidities. Many diseases are associated with obesity, for example, coronary heart disease, stroke, and type 2 diabetes. The risk of obesity-associated diseases is clearly connected to the level of obesity. We see in that graph the level of obesity on the x-axis defined as the body mass index. And we see the higher the body mass index is going, the higher the risk will be. And this is going in an exponential manner for all obesity-associated diseases. The impact on such diseases for the patients, but also for the society, is that they reduce the length of life, they reduce the quality of life, and they increase the costs. So preventing or treating obesity can positively influence these diseases and the related impacts. One issue about that is that these diseases develop over a long time horizon. So we have the issue that long-term clinical studies are required to investigate the influence of an intervention on these diseases. And here we have two issues. So we will require massive funds to run these trials, and it's simply requiring a long time horizon. And as we have the situation, this time and funds are often limited, commonly more short-term clinical studies are performed. And as a decision is required on the best strategy for treating a patient, right? And we like to have the decision as soon as possible. Health economic models are often used. Such health economic models predict the long-term consequences on one hand, on obesity-associated diseases, on the length of life and quality of life, and on the associated costs. And usually this happens then by comparing an intervention to a current standard. So these health economic models translate these short-term clinical study outcomes or results into long-term consequences. The outcomes of such models are usually used to decide whether a healthcare intervention is to be funded by healthcare payers. For such adoption decisions, decision makers and payers need to rely, meaning they need to trust the results of such health economic models. Modelists can impact such trust and enhance model credibility by transparency of model reporting and by model validation. So both of these central aspects were investigated in the thesis. Before we are entering the presentation of the key results, I'd like to show you that, well, the whole chapters of the thesis are interconnected, and the previous chapters are informing the following ones. So we started with a systematic review in health economic models to see what is there, what are health economists usually doing, right? And we had a deep dive into the methodological variations and into the model validation. We used then these two chapters to inform a health economic expert panel, simply to see whether it's possible to define key qualities, criteria for such health economic models. And using these expert recommendations, we selected high quality models and performed a model replication and also investigated the reporting transparency. And last but not least, we used the successfully replicated models and performed an external validation and investigated the impact of different methodologies used on the health economic results. Well, with regard to chapter 2 and 3, I'd like to guide your attention to two central findings. So first of all, it was very interesting to see that many modeling teams build their own approach. So we have a lot of unique models out there, and that's quite uncommon because usually we health economists tend to use what is already there, right? What is already published. And here we see in around about 80% of cases we have unique models. And this is accompanied by the fact that only 14% of that looked into model validation, right? So we have really a lack of validation combined with a lot of unique approaches. If we are going further down the road of the methodological variations, for sure we can look at which diseases were simulated by specific models. And well, we see at the top 3, and I'd like to guide your attention on that here: coronary heart disease, type 2 diabetes, and stroke, as they together were used by more than 50% of the models, right? So that's often integrated in each models, or at least at the majority, which is why we focus on these 3 diseases in the further research. Well, we had then a really deep dive into the question, how were these events simulated over time? And how was this event simulation informed? And we were able to identify 3 different key approaches that you see here. And I like to guide your attention to the orange bar, which is simply showing the average, or on how often or how frequently an approach was used over all those 3 diseases. And we see on the left-hand side a very complex approach where sophisticated risk equations were used with many, many risk factors informing those equations. So they are very data intense. And we have also simplified approaches that use the BMI or a BMI group, meaning as a continuous or a categorical variable, either by applying a relative risk to a base risk, or by having BMI as, well, the only part influencing a risk function. So, and this was used by around about 60% of models. These findings lead to 2 main research questions. How complex does a health economic model needs to be? Meaning we have seen the risk equation approach, which is very complex and very data intense, and the BMI-based approaches, which are simply a simplification, but you only need a BMI to simulate events over time. And second, what impact has the modeling approach on the results? On one hand, on the clinical modeling results, and on the other hand, on the health economic modeling results. Well, we used then the findings of the expert panel in order to select these high-quality models, and we selected 4 different case studies and performed a model replication. And we see these models use different approaches for the risk calculation. Also, this very sophisticated approach with the risk equation was used twice. All were using a long-term horizon, looking at least at the events of interest for us. Were simulated in a UK setting, and all were using quality-adjusted life years as the central health outcome. Well, we tested then different criteria for the model reproduction success, because this was the first time done in health economics. But I'd like to target your attention on one specific finding here, which is simply looking at the key health economic result, right? Meaning the incremental cost, so per incremental effect in the so-called cost effectiveness coordinate plane. And we see here on the epsilon axis the incremental costs, on the x-axis the incremental effect in quality adjusted life years. And we see here one result related to the original model and one result related to the reproduction. And here for case study 1, we simply see, okay, also both are located more or less on the same height, meaning the incremental costs were predicted quite correctly. We see a huge distance with regard to the incremental effect. And that's something we don't like to see. In the best case, we like to have these points very close or even overlapping. So, well, this situation was getting better for case study 2, right? So still better incremental cost prediction, or than the incremental effect, and then even better for case studies 3 and case studies 4. And also we have used different criteria. This was really one key decision maker to say, okay, case study 1 was a reproduction failure, and the case studies 2, 3, and 4 were a reproduction success. So using these successfully replicated models, we performed an external validation to investigate the validity of the underlying approaches. So this external validation compares modeling results with actual event data. And here we used the Swedish obesity subject study, which was a large cohort of severely obese patients that were followed over a long time horizon, so over 18 years, comparing surgery versus control. And using this data then and the models, we used model simulations and then, well, investigated the goodness of fit by comparing the modeling results to the SOS data, and we performed that for each of those modeling approaches. And well, I like to then show you a summary slide on our findings with regard to the validation of clinical events. We see here also, well, we used the simple school mark system to show the grade of deviation. And so 1 is the best mark here, and 4 is the worst mark here. And I like to target your attention again on the orange bar, which is showing the overall or average results over all the events. And we see that a risk equation approach with 2.5 on average mark was performing better than the BMI-related relative risk, was performing slightly better than the BMI group function. That's the clinical part. The health economic part here, we had a look at the health economic key outcome, which is the incremental cost per QALY gained. And we performed 10,000 model simulations also to investigate the deviation of results, and plotted that here in the usual box plot display. And here we see within the box 50% of the results are located. The cross shows the mean, the line the median, and the upper and lower fences are defined by the interquartile range of this 50% results, the 1.5-fold interquartile range. And if we look to the left-hand side, which is representing the 80-year time horizon of the study, we see, okay, there's a difference with regard to mean and median between the approaches, but there's already an overlap of the 50% confidence interval. So meaning from a statistical point of view, we would conclude there is no difference in the health economic key result. And the same was seen for the lifetime horizon. Well, so let's conclude that a complex approach is required for adequate event prediction, but not to adequately predict the incremental cost effectiveness. An impact of this finding is that health economists and decision makers have better guidance on how a specific modeling approach might influence clinical and health economic model outcomes. This might lead to increased trust into health economic modeling results and potentially to faster adoption of innovative prevention and therapy methods. in the context of obesity. So thank you very much. This was the presentation.
Thank you for your summary and conclusions. And the opposition will be opened by the chair of the assessment committee, Professor Paulus.
Thank you, Pro-Rector. Dear candidate, with great interest and pleasure I've read your dissertation, and with 5 chapters published, I think it's an impressive body of work, for which I congratulate you and also your promotion team. Nevertheless, as you can expect, I also have questions, and my first question is related to chapter 4. In that chapter, you try to, let's say, formulate a minimum set of requirements, and you use interviews and an expert panel for that. And my question is related to the transparency of certain parts of that research. Let's start with the interviews, just a matter of clarification. If I understand it correctly, you say you interviewed 10 experts, is that correct? And it was not interviews like we usually, let's say, presume they are interviews like face-to-face, or could you elaborate a bit on that?
Okay,
what did
sure.
you do?
Well, highly esteemed opponent, thank you very much for your questions and for your feedback. Well, how did we perform that? The point was, first of all, for sure, we selected health economic experts where we have had an idea, they have a background in obesity modeling and have an idea on that. And what I did, we did no face-to-face interviews really in one room, but what we simply did were video interviews, right? So I had online meetings with them and simply presented our previous research and our findings, and then guided them through a set of specific questions. So we had a predefined questionnaire that we were working through with each of the experts in order to try to get, well, comparable answers, for sure, from the different professors, which was quite ambitious. So as you could imagine, because there is no truth in science, right? And so I think this was the point that was the reality check for me.
And these 10 people you interviewed, that were the same experts that were members of the expert panel then?
Yes, so that's then, they were invited then to have a face-to-face expert panel, and we had that in the frame of the UHIA Congress here in Maastricht, and had then the opportunity to simply discuss what I have learned in the single interviews, with the idea to better align those different answers. And in some aspects this was possible, in others simply the experts tended to have different opinions, which we have also transparently reported in the paper.
And well, you just elaborated a bit on the experts. You said they're all health economists. So when I was reading your chapter 4, I was thinking, well, who would qualify as an expert? Just to give you an example, I've been working here at Maastricht University for 33 years. I studied economics, and for 26 years I'm working in the field of health economics. Would I qualify as an expert?
Well, we simply had a bit of look. I was also a member of a special interest group on obesity from the IHEA. And for sure, we also try to use that group a bit, and the members of that group that are specialized on obesity and health economics, but also simply had a look, okay, who is doing research into obesity modeling here at the Maastricht University. So we've taken those people additionally on board, and that was a bit setting the frame for selecting the experts. And well, it's always hard to make that clearly, right? You have always a specific selection bias, and that's something I think we also clearly have by this European setting, right? Because we would also love to have US experts or Asian experts on that topic, and it would be interesting to go into that direction and see, are there differences when we're doing that on different continents?
Oh. Because if I understand correctly, you say it was more or less a convenient sample, but people did have to meet certain criteria, like being health economists, being into obesity and health economics. Is that what I understand are the in or exclusion criteria?
That's the criteria we had.
Yeah. And then you assemble them together in an expert panel to arrive at a kind of a consensus on the minimum set of requirements.
Absolutely. What I simply did is I presented them the findings of the interviews.
Yeah.
So question by question, and then simply said, okay, let's discuss about that. So why have you chosen one or the other in order to see, is there any way bringing them together, or are these simply totally different opinions on a field? And well, this was really also my learning. Okay, if you have 10 professors in a room, you have 15 opinions. Yeah. And so it's not easy to come to clear conclusions, but I was happy that we were able to align on some key aspects, and that's already a great starting point.
Yeah. Yeah, it's like you say, it's always difficult with so many economists in the room. That's always also the running joke. Put 3 economists in the room, then you have 4 different meanings, or maybe 5. But what I was wondering, in hindsight, you opted, let's say, for this more online kind of interview, and you opted for an expert panel meeting during a conference. But did you ever consider a Delphi panel approach? Because you are looking for consensus, and a Delphi panel approach is the approach to, let's say, arrive at consensus with experts. Did you ever consider that? And maybe a small answer.
Indeed, we had a discussion on that, whether it would be a valid approach for us. The point was, we were really knowing too few about the topic. So it was the first expert panel we run, and so we had no idea what answers we will get, how different would that be. And well, we had this quite small sample, and there the question would have been, okay, would we have really reached something on top, right? So Delphi, I know it's really nice and methodological, I think, rigor to do that, and if there is a great sample with maybe using the learnings from our research to try to dig into a consensus there, it may be a nice future approach to do so.
Thank you. I'll return the word back to the prorector.
The opposition will be continued by another member of the assessment committee and the honorary secretary of this degree committee, Professor Kremers.
Thank you very much. Dear candidate, my congratulations for the nice work that you did, and the way that you wrote it down in your thesis is really impressive. So really well done as far as I'm concerned. But I have some questions, and my questions reflect chapter 6. Mm-hmm. If you look at the results, you might want to say, from a clinical perspective, the more you measure, the better your predictions are, more or less. Mm-hmm. Maybe let's just start with a closed-ended question, which means that you can just use one word in your answer. Yeah, of course, you have an issue there, esteeming me and stuff like that. But then I want to hear yes or no. From a clinical perspective, what the results from chapter 6, did they surprise you?
Yes.
Yeah. And I'm highly esteemed, and I know that that's true. So they surprised you, and in what way?
Well, highly esteemed opponent, thank you for your compliments and for this question. What did surprise me? I think I would have thought that the approaches were performing better than they did, because what we usually see if we look into the literature and look at those models that provided validations, they are all positive. Mm-hmm. They are all positive. So, and I think what we are facing here is a clear publication bias, right? So, because if I build a model over years or invest a lot of time and then run in validation and the results are not so good, and I have not wrote a plan that I will do that, right? So I tend that there is maybe the tendency not destroying the own model.
Okay, yeah.
And so
I'm going to interrupt you here
Yeah.
because this was just setting the stage.
Okay.
But it's interesting. People put in a lot of effort in making
Yeah,
like
sure.
Wikipedia's kind of scores for predicting, etc. And they might do better, especially in relation to the trust issue that you have commented upon earlier. Maybe I come back to the trust issue later in my questions. Two of the scenarios that you compared were, let's say, the linear BMI-based approach versus the categorical based approach. In essence, of course, both are using the same data. And actually, my initial thought would be, okay, of course, the more information you have in the linear approach, the better it will work. So why did you actually consider combining the BMI into rough categories in the first place?
Yeah, well, what we simply did is, so we used approaches there that were commonly used by health economists. And so, as you have seen in the beginning of the presentation, this categorical is also used quite frequently, I think, in 20% of cases, right? So it was a valid question for us to see how might that perform in comparison to the continuous one. The other thought is simply coming from the health economic point of view, because if we are using a categorical one with regard to health economic results, we tend to go into a more conservative assumption. We simply assume that not each change in BMI has an impact on those risks, but we like to see clear changes, so bringing people to other groups, which is maybe more in line, but I'm no clinician, what you see in the clinical field, right?
Yeah,
and,
totally agree. The clinics like to put people into boxes. You know, you're this and you're that. While in essence, of course, you know, an increase in BMI from 29 to 30 then makes a difference, while from 31 even up to 34 wouldn't make any difference at all in terms of, you know, putting people into boxes, which is, of course, maybe from a clinical perspective, has some logic to it. For a researcher, that would be stupid.
Well, I agree with that, right? For sure, having no impact there. On the other hand, I have a feeling that controls a bit for this point of when have I reached a clinical meaningful change. And I think that's taken out of the game if we are looking at a continuous one, right? I personally have no preference for one or the other. To simply say that I'm trying to understand why people might use the categorical one, right? And or like to elaborate on that. And I could understand that there are reasons for that. My personal preference would also always be the risk equation approach, right?
Well, okay, yeah. I do have a personal preference, but maybe that's, you know, the behavioral scientist in me that that speaks there. But okay, I think it's really elegant for you to be objective in that perspective, and also be able to review other people's approaches. Maybe then get back to this trust issue that I announced before. You used the word a couple of times in your presentation and also in your dissertation, and your aim actually of the thesis was to increase the trust that decision makers could have in health economics and the use of those kinds of decisions of information for policy decisions. So how can we then increase this? So what is the key element of what we should do in order to use your thesis? I read your impact paragraph, but I didn't really see the main thing, let's say the leverage point that we can use to increase this trust.
Well, I think there are different perspectives, but to try to make it quite short and clear. For sure, we have seen that all models or health economic models are not perfect, right? Especially looking at the clinical events. But what we have seen is, if we are looking to the health economic results, they tend to come to the same conclusions. And this is a fact that would increase trust, because if I would be a decision maker, I see, okay, the approach does not seem to matter that much if I'm only interested in the health economic decision making, for sure. If I'm interested in the clinical events and the simulations over time, I would say, well, we might need to have better models, right?
Yeah.
And I think then more the epidemiologists are coming into the game, because so health economists, we simply tend to oversimplificate models, right? To make it easier to understand, also to explain it to decision makers. There are often no health economists, and the more complex it is, the harder that will be, and that's always the trade-off, right? How much trust do you have in a very complex model where you have no clue what's happening inside?
Yeah.
Right? So that's a bit, but the key point is, I see, irrespective of the approach, the results will be comparable somehow.
Okay, thank you very much.
You're welcome.
Give the word back to the project.
Your position will be continued by Professor Roefs. She's a professor of psychology and neuroscience of abnormal eating. Professor Roefs.
Dear candidate, it was a pleasure and also a challenge to read your thesis, considering my different background. First of all, congratulations on your impressive piece of work, and also to your supervisory team. And I would like to hear your thoughts on two related topics. And the first one relates to chapter 3. And you described there that empirical studies on the effectiveness of interventions typically measure outcomes up to maximum of 2 years. And then you write that in your modeling approach, you are extrapolating to even a lifetime horizon. And you also mentioned that in only 10 of the 87 papers that you included in your review, an external event validation was performed. And I was wondering, how can we say anything then about the validity in the other 77 papers? How do we know how these models perform? Could you give me your thoughts on that?
So thank you for the question and for your positive feedback, highly esteemed opponent. With regard to your question, well, how can we test the validity? And that's the point. We can't, right? So if they don't perform an external validation, then I don't really know what's happening in those models, and I don't know how does it compare to others. And that's the big question mark, or also I would say the big finding we had on the basis of the systematic review. It was really impressive and also a bit shocking. So first of all, that everyone built his own approach, right? And second, that there is so limited external validations out there. And then we are exactly there, what you're mentioning, how can you trust those, right? So how valid are those? And we could maybe, and that's what I had in mind when we started that research. I was a bit expecting a situation like in type 2 diabetes. And in type 2 diabetes, simply another chronic disease that is also playing into the game for obesity, we have a limited number of models out there that also validated a lot. They did a lot of cross-validation and a lot of external validations, and so the models developed over time. And I personally would have expected the same happening on obesity, right? And that was really also for us the interesting finding, right? To say, okay, we have so many unique approaches with so few external validations.
Yeah, and what I also noticed, if I understood it correctly, the focus was very much on data from scientific studies. But aren't there a lot of data available in routine clinical care that could aid the development of these models? Or did they do that and did I miss that?
Well, it's the question how good you could integrate that data from the routine clinical care. Often well, we health economists tend to have a clear research question. So intervention A versus control. And then the best starting point is, okay, are there comparative studies available, right?
Can I interrupt you? I understand with the different interventions, but there's different ways to achieve weight loss, and you know that.
Mm-hmm.
Does it then really matter by what way it has been achieved in these models? Isn't the success of the intervention more relevant, and could you then combine more data?
Well, that's a good question. We don't know it, right? So weight loss is one part of the game, and for sure looking at a simplified view, I think, and I as a health economist like simplified views, we could come up with the conclusion, okay, losing weight in a specific way brings us to the same results. Mm-hmm. So, however, as a human, I don't believe that.
Mm-hmm.
Yeah,
okay.
because simply we see there are many approaches out there, also highly interventive, invasive ones, surgical approaches, and so on. And also from my personal experience, I know at the end you need to change your behavior. And you need to change that over a long time in order to also make the results being constant, right? And that's also a thing we often are not sure about as health economists, what happens after that intervention. And one big assumption we always have in that models is how might the BMI or the weight or the risk factors develop after the intervention and after the study time horizon. And there we usually simulate different scenarios that could happen, but we don't know. And I personally more believe into behavioral approaches, right?
I'm of course very happy that you say that. And then I would like to continue to chapter 6, and there you present a validation study. And what I noticed is that for overall mortality and fatal cardiovascular events, there's consistent mild to very severe overprediction across all models. But if you look at total cardiovascular events, and also for type 2 diabetes, some models overpredict, some underpredict. Mm-hmm. And it puzzled me, and could you explain these discrepancies between the different outcome events? So how can it be so different for different outcome events?
Yeah, so highly esteemed.
So your challenge would be the candidate to answer in a very economic fashion.
Very good.
Within 1 minute, please.
I will do. Well, we know from the SOS study that they have expected more fatal events from the cardiovascular field than they have seen, right? And so I think it's a bit study-driven, but also what we see in the studies. Maybe we overestimate the mortality in obese patients due to cardiovascular events. I don't know. That could be one fact, because that the authors of the studies mentioned. With regard to type 2 diabetes, well, we simply have seen that the simulation approaches were informed by different populations, and overestimated were coming from an US population. Mm-hmm, mm-hmm. And so this might not be really transferable to European setting in very short box.
Thank you very much for your answers.
Thank you.
Your position will be continued by Dr. Redekop. He's associate professor at Erasmus University Rotterdam in health technology assessment of healthcare intervention, and he is online with us.
Thank you. Dear candidate, let me first compliment you and your supervisors on a very relevant and thought-provoking thesis. I really liked your use of different methods during your research and throughout your thesis, and I actually enjoyed evaluating it too, because I found it very readable, and as I say, it was very relevant. And I'm therefore very glad to attend your defense here, even though I wasn't able to be online today, or wasn't able to be there in person today. I want to focus on chapter 6, where you compared the cost-effectiveness results from different obesity models. And it was clear that you faced different challenges. I won't go into all the details. You know them better than I do, but it was clear in your documentation that you had to make these different decisions. And it wasn't an easy process, but that's why this paper earned a place in your PhD thesis, of course. Now, like many others, I was particularly interested in seeing how much the incremental cost effectiveness ratios differ between the models. And to my surprise, and evidently to your surprise, you found that the differences weren't very big. I mean, ICEs ranging from 2,000 to 6,000 euros to gain one quality doesn't seem very big. And moreover, since those results are very small, the differences in results are very small, that means the conclusions about cost effectiveness would be very, very, very similar. So a quick question, which really only needs a quick answer. Does this really mean that we can choose any model we want, since it won't affect the cost effectiveness as its conclusions? This seems to be what you're suggesting at the very end of the chapter.
Well, esteemed opponent, thank you very much for this question, for your compliments, and well, to make it very short, I would not conclude that you could use each model, because we were not able to investigate each potential modeling approach, right, that you could imagine in health economics. So if you're asking for my personal opinion, I have a long time the feeling that we health economists are discussing a lot about different methods. Also on the incremental cost effectiveness frame, we see not a large impact. So we had the same discussions in the past, and I personally have not understood those, on how to simulate survival in oncology trials, because I was working in different oncology models, and irrespective which equation I added in sensitivity analysis, I was always coming to the same cost effectiveness conclusion, and the results were very close. So my personal finding of that is, as long as you use comparable approaches in each model arm, right? So the incremental results may not differ that much, and maybe we should keep that in mind for simplifying models and maybe concentrate on areas that really have an impact on those results. But that's my personal idea.
Yeah. Okay. Thank you. I think you got my point. I think you as you mentioned elsewhere in your thesis, you like the pragmatic approach, right? And that's what we see here. One thing that I wanted to ask you then is, if we have to choose which model is best, what other criteria could we use? Is it we can think about the time needed, we can think about expertise, we can think about data. Are there any kinds of rules of thumb that you would want to recommend to decide in the future?
Well, that's also a good one, and it's hard for me to give a general opinion, but for sure I have a personal one, right? And so the question, and I know. So we health economists always say we should not build a modeling approach on the basis of the data available, right? And look on the large picture first and should simulate what makes sense. But in the pragmatic world, I think we only have the data that we have. And as I have told before, if I really have data on different risk factors over time, I would always go with this sophisticated risk equation approach, because so it makes for me more sense from the clinical point of view, and so I feel better, right? I tried the best. However, in reality, we have many studies in obesity that does not fulfill that criteria. They have not measured all those risk factors you need to feed all the equations, and well, in that case, you would need to assume an impact on those risk factors, which makes also no sense. And then you tend to go back to such simplified BMI-based approaches. And for me, it's then a clearly data-driven decision, really clear pragmatic decision-making from a modeler perspective.
I would suggest, one recommendation is probably should go to the trialists, the people who do the studies, right? So basically saying, it's you don't have to reduce your modeling just to compensate for the lack of data, but rather in future studies, right, where we're talking about millions and lots of money being spent, we should put the onus on the burden on the trialists to collect the relevant data so that we can use the better models, right? Should that not be one of the recommendations?
Well, that's always the starting point, right? So the better the underlying studies, the easier is our work. And well, if studies would be perfect, we would not even need to model, right? Because in the perfect world, I like to see a long-term trial that shows directly the influence on the obesity-associated events. And then I would say, okay, sign it off, that's super. We do not even need to add costs on that. It's making the life of patients so much better. But we always face that patient-centered approach, and that's why we like to have fast decisions, right? And then we see, okay, there seems to be an intervention that has good results, but we only have the short term. But how could that translate into long term? And if this is really good, that's something we like to use in the healthcare system to simply make patients less suffer, right, earlier. And that's a bit the two roads, right, and the two hearts that are beating there, because so from a clinical point of view, as a physician facing the patient, you like to know what's the best strategy. And so that's something for sure we also try to support.
Thank you very much, Dr. Redekop. I have to stop this discussion, lively discussion, but I'm sure you can come back to that later with the candidate. The opposition will be continued by Dr. Freyer. She is a researcher in nutrition economics at Erasmus University.
Thank you so much. Congratulations with your outstanding thesis, dissertation, also to your team. And I also have a question regarding the chapter 4. Mm-hmm. And it would not surprise you that I will ask you something about the experts that you had. I was wondering, do you think that the criteria you mentioned in chapter 4 would be different when you would have some clinicians in your expert panel?
Well, esteemed opponent, so thank you for your compliments and thank you for the question. Well, sure, I think would the results be different, maybe framing it from another side, right? If my goal would have been so building a perfect model or a really valid approach, so we would always include physicians, not only physicians, but stakeholders from different perspectives into the development, because the health economic viewpoint is really limited, and we know that. However, what I simply tried to achieve with the whole approach was to see what are we health economists doing there all the time. So, and putting aside, does it really make sense, right, from a clinical perspective to simulate it that way? Because I see we are doing that. And so the question was more, okay, if we are doing that, how valid is it, right? And so these are a bit, hopefully this goes in the direction that you like to hear. I would not have liked to have clinicians in there because I had a gut feeling they would have thrown out some approaches from the very beginning, as they make not really much sense from the clinical point of view. But for me, it was important to investigate how valid these approaches are, because they are used. They have been used in the past and they are still used today. And so it's simply good to know what's the result of our doing.
Yeah, thank you so much for your answer. And what do you think then about the recognition of health economic models within the clinical environment? Because when you're talking to several stakeholders, mm-hmm. do they understand what you are doing with this dissertation?
Well, It depends on the background, and for sure, this is really a deep dive into methods, and it's very methodological. But also, I think we were able to create a clear conclusion on that and how we would interpret the data and the finding. Transporting that to clinicians, I think, is the more ambitious point, right? And I think that needs time, right, to transform. But I think the message is clear. Maybe don't always trust what we are simulating on the clinical side, but that's not our key aim. Often we are interested on the health economic outcomes that are often required to bring new innovations into the hands of clinicians. And I think that's why usually you have clinicians that are quite open, right? Quite open for what you're doing because they like to have more options for their patients. And so they also try to make that happen somehow. And so I believe they will understand what happened here, especially those that are involved in such health economic modeling, at boards and so on.
Yeah, thank you so much. They should work together, the health economists together with the clinicians, together with all the other stakeholders, to be able to really know what the best intervention is at the moment and so on. So thank you for that. And just another question. You mentioned also the core obesity model. Would that be then the main message for me to come back to the Erasmus University, to all the clinicians and all the people who are working and researching the obesity, to work with that model?
Well, I don't like to promote the model from one vendor here, right? But they were very smart into recognizing the demand of a validated model. And they simply did a nice work. They have the core diabetes model, they have experienced people, and they saw, okay, a lot of the story is coming from the diabetes side here, so it's maybe not that wrong using an existing model and transferring that a bit into the obesity section. And so without promoting the model, I would love to, or I personally like to work with validated models, and then there are not so much in the frame. What I personally expect is that others see the demand, and in my personal hope, we will have a situation like in type 2 diabetes where you have then different teams working on a sophisticated approach and do cross-validations and external validations to simply bring that forward. That's my personal wish. They have a strong position now, I think. Yeah.
Okay, thank you so much. Do I have still very small? Just one question regarding the World Obesity Day. Every year, on the 4th of March, there's a World Obesity Day. What would your message be towards the world? What to do? What is the solution for this still increasing societal problem?
Well, I stopped a long time ago with having a solution for all world problems, but for sure I have an opinion on that, and I personally would love to see a world that is more influenced by knowledge and less by capitalism, and so that we have this ongoing discussions on it's no good idea to label the food into green, red, and so on, and we are not coming really to an end here. I think such things simply need to happen, because if you are not really into nutrition, this is something that comes too short on all the school education systems, right? And so you need to have a clear guidance for people, and so politicians, in my point of view, should not stay in the way of that, but simply make it happen.
Thank you so much.
Yeah. You're welcome.
I would like to thank both opponents from so far away, from Rotterdam, to be present here in online and not online. And the opposition will be continued by Professor Dirksen. She's a professor in health technology assessment of clinical interventions at the MUMC, Maastricht.
Okay, thank you. Okay, dear candidates, congratulations with your thesis. So we have about 6 minutes left, so I will move to my questions quickly. And maybe can I invite one of your paronyms, Dr. Ramakers, to read proposition 5, please.
Trust and confidence in health economic modeling are central factors to ensure the best allocation of scarce resources in order to improve the health of individuals and the whole of society.
Thank you, thank you. My first question, I hope this is not a mean question, but it's just a warming up question, I hope, is you talk about trust and confidence in your thesis several times, because it's one of your aims to increase trust and confidence. Can you please give a short answer? What is the difference between trust and confidence? I'm not a linguist, so can you explain this to me?
So, highly esteemed opponent, so thank you very much for your feedback and for that interesting question. Well, trust and confidence, I'm also a linguist, and I have a short answer. I will not try to do a differentiation there. I think there are some overlapping meanings here. I think if we have two circles, there's a lot of overlap, and there's some other meaning to the one or the other. As we health economists are no linguists, you usually see that in the literature named together, because we can't decide what is what and what's more important. And so I simply tended to use what maybe also smarter people than I already put into guidelines. I have no answer for that.
Okay. So I just have to put these terms together, and they just represent one concept. Actually,
I would think so. Yes.
Okay. Well, then of course you in this proposition you also refer to the best allocation of scarce resources, right? And I was wondering, because you did a review, a broad review, a broad inclusion, and there are several models, several target groups, several therapies. It's prevention or age groups, etc., etc. So you get a lot of different models. But I was also wondering, because most models are born because there's some kind of a decision problem there. And I was wondering, did you also look at that? Were there all kinds of different decision problems? Why the models were built anyway? Can you give a short answer for that?
Well, yeah, usually we tend to build models in order to have that translation from short-term into long-term, right? And that's even more relevant looking at prevention, because you like to know what's happening in the long term. If I continue that, so all have or facing a bit the same issue. I have short-term results.
But short interruption. I mean, sometimes models are built because there's a need for a reimbursement decision, for example, or is it just an academic exercise, or is it to inform guidelines? So what were the models used for?
Well, I think the majority of models are really trying to convince healthcare payers, right? Because we simply see that most of health economic models are tended to be published for countries where this decision making is also involved by specific cost effectiveness thresholds. And especially in those countries, you have clearly the idea of, okay, making it happen, so bringing those into the coverage of a health insurance system, and so to the patients. And for sure, you have also the other side you have mentioned. So if I, as a German, do a model for Germany, it's nice to have, because the German authorities do not really care a lot about that. However, I think there's also one step further. We always try, as a German health economist, to convince politicians and to convince payers that it's important looking at that aspect. So budget impact is so limited. And so it's also something we continuously try to bring into the field and to discuss.
But I was wondering, because in the Netherlands we have formal decision-making process for pharmaceuticals, for example, and then so the heterogeneity, I'm a bit surprised. So if models are used to inform payers and to inform reimbursement decisions, how come there's so much heterogeneity in the models? Because you would expect that that there are clear guidelines for those models.
Absolutely. I think in obesity we're facing a difficult situation for bringing simply approaches into coverage, because we still have the issue in many healthcare systems that is not really seen as a disease, but more as a lifestyle issue. And so you got it on your own, so care for it on your own. We are not responsible for that. And that's simply driven by two issues for me. From one point, it's more, well, seeing it's not really a disease, right? That's one issue. The other issue is we really have this lack of clinical long-term data. So it's not a coincidence that we have the surgical approaches reimbursed with those big studies behind showing there is an impact, and the others not. And so we are simply facing a bit of situation. Also, big models and changes are often driven by big money.
Yes.
And pharmaceutical industry was trying a lot to bring their products into the market, and they not succeeded. And so there are other approaches in the system with less money, and so you have this short-term trials and so on, because you don't have the financing, which brings me simply to the question, maybe we should finance such long-term studies.
Well, that's maybe my last question. How could you do this? Because what you state here in your thesis that we make models because there are no long-term data. And on the other hand, you state, well, the external validation is a key limitation of those models. But that's a little bit of a paradox, isn't it? So how could we funnel more money into research? I think the problem is especially there in prevention research, and not so much in surgery, bariatric surgery. So how can we get more money into that very important area?
Well, I'm no politician, and I will be none, right? For sure, I have an idea on that. So there are simply things that are important for society, and we should spend money for those as a society.
So the medical faculty is allowed to end your sentence. But if you
I love to make that point, because I think it's really an important one. I think for some things, society should make the decision to invest also in these long-term studies and not leave it to the industry. The industry is not a solution for everything, and who has not learned that now, I think, is a bit on the wrong track. It's only also my personal opinion.
Thank you very much for your answers.
Björn Schwander, the time appointed for defending your thesis has passed, as you noticed. The degree the committee will now withdraw to discuss the quality of the thesis and of your defense. I request that you and your company awaits the results of our deliberations here in this room and wait until our return. Thank you very much.
Thank you.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Southside, 10 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Get the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you won the battle once you've grown. Southside, 10 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
quasi Fragebögen mit dem ganzen Quartier gemacht. Und dann kamen immer wieder Dinge raus und die Schnittmenge ergab dann die Einrichtungsplanung. Das ist toll. Also,
Also das gibt natürlich auch das Gefühl, dass jeder da irgendwie...
Ja, das war jetzt pointed downwards.
Ja, so ein Partizipation.
Ja, genau. Ah, schön. Ist natürlich auch immer dann in 5 Jahren die Frage.
Ja.
Aber was mal
That's now I'm happy. It's done.
Genau.
Ja, das wollten sie alle.
Ja, genau.
Nice dinner.
Genau.
And,
Aber okay, das
don't
hört sich
care about
schon
the
sehr
PhD.
schön an. Ne?
Björn Schwander, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Evers is authorized to confer upon you this academic distinction in accordance with Dutch university custom. She will first ask you to say yes to a declaration of academic integrity and then will hand you over the sealed degree certificate. I invite your supervisor to now take the floor.
All right. Is the microphone? Yeah, it's working. Do you promise to work in accordance with the principles of scientific integrity, at all times to be careful and honest, transparent, independent, and responsible?
I promise.
Okay, that's great. By the authority vested on us by law, in conformity by the decision of the committee here present, I hereby confer upon you, Björn Schwander, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the Maastricht University.
Dear Björn, dear Dr. Björn Schwander, you have done it. The PhD project has come to an end. It is my honor to be the first on behalf of your promoter team, Sylvia and Mark, to congratulate you, but also your wife and family on this big accomplishment. We already met in 2015 and started a collaboration. At that time, you probably never expected to be done in 2023, 8 years later. It took certainly a few years to have your PhD, but an external PhD is very, very challenging. You were working full-time, you have a child, you moved to a completely new area of Germany, and publishing, doing research take a lot of time. But you never give up. You published all 5 papers of your dissertation, and it became always more and more easy to have your article published, and in top journals with 2 articles in pharmacoeconomics, by example. Your enthusiasm, your determination, and your passion for the topic were without a false note. We are proud of your work and are convinced this process allows you to become a better researcher and academic researcher. Today, we are pleased to see you and your wife at Maastricht, a day that will certainly remain very important in your life. Your good mood in our Zoom meeting, the sharing of some of our local habits will miss us. but we are confident we will have opportunities to be in touch and to meet in the future, including in congresses where we already had the opportunity to take coffees together. We thank you for the present collaborations and wish you all the best in your professional and private life. And Mark will also say you a few words. Congratulations again.
Thank you very much.
So, dear Dr. Björn Schwander, I will go back to history. So we initially met by our mutual friend Stefan at social event at annual ISPA Congress, also with Ken and our German friends. So later you invited me also for advisory board meetings, which we combined with other social events. I remember we went to Dortmund, Bayern, Munich, also with Stefan, and also World Championship Soccer in Germany. So you also from a medical background like me, and we both shared high interest in health economic modeling, so we had something in common, and also in the end we also had a professional connection. In that period I was involved in a PhD project in nutrition, also with a person doing it besides the work. In fact, it was Dr. Karen Fryer. And she was getting to an end to that, so when we were discussing that, you got interest following the same pathway for a PhD. So you selected a very, and I brought you in contact with I remember ISPOR in Amsterdam with Sylvia, and then we discussed your interest, and then you came with a proposal. You selected a very challenging thesis subject, health economic modeling in obesity. Especially its methodologic interesting because of the complexity. So anything which you will find out for modeling obesity because of its complexity, you can assume would apply also to other modelings, other diseases, and also it has a high interest for public perspective because of the high cost, high prevalence, and high morbidity of obesity. You were able to use obesity modeling to address a number of general but also interesting new methodological issues in health economic modeling in general. I think especially the replication is quite innovative, and also the approach you developed. You were able to find optimal approach by going into details for scientific research, but also by taking a broader perspective when considering the general findings of your your PhD to health economic research guidance for in general. Your PhD was a challenge because you had to combine it with your busy consultancy activities, and but you were always able to, or you always prioritize quality to progress, and therefore your research resulted in very solid publications in very renowned journals like Pharmacoeconomics. And also because of the work take more time than expected, but it was there were concrete. The publications were, I think, showed a tangible process and gave the motivation to proceed, and we saw deliverables, if you call it that way. So in fact, some steps took a bit longer, but you were always able to keep the train running, I think. So we had never any doubt that you would never reach the end station, which is today with your graduation. I joined your Zoom meetings, Congress meetings with you and Sylvia and Michael, and it was an honor to be part of this journey. I wish you all the best in your professional career and of course also personally, and look forward to continue our scientific collaboration and our friendly contacts in the future. And once again, I want to end with congratulating you with this excellent PhD, and also congratulations for Carmen. Yeah.
Thank you so much. Likewise.
Dear Dr. Schwander, as a Facharzt für Allgemeinmedizin, I noted unanimously that the degree committee noted that you are a health economist with a human heart. So that's very, I think, on a good note. So after the closure of this ceremony, we take some pictures here with Dr. Redekop in fully present, in full color. Okay. And then at the stairs without Dr. Redekop. So on behalf of Maastricht University, I congratulate you with the degree that you have acquired, and I close this session.